So on is the mic is on.
Okay.
And then on before you start. But yeah, that it's on.
Turn it on.
Yeah, that's
Okay.
on.
We'll get started in about 2 minutes. It's really wonderful to see everyone so excited to see one another. I'm going to ask everyone to try to take their seats. So, we have some people on Zoom as well. So we'll get started. So thank you so much for making time to come to our inaugural grand rounds for the academic season. So my name is Dr. Nita Palpu. I'm the head of the PhD Department of Medicine, also department head at UBC. And first of all, I want to acknowledge that we are at St. Paul's in the unceded traditional and ancestral territories of the Coast Salish people, the Squamish, the Musqueam, and Tsleil-Waututh. And we're very grateful to be on these lands that have been stewarded from time immemorial. And we are committed as a department to the TRC calls to actions, particularly 23 and 24, and also in our care to respond to the In Plain Sight report in providing care that is culturally safe. So the purpose of this lectureship that we have is to provide an opportunity for a medical, academic, or scientific expert to deliver a presentation with the theme of medical ethics and or professionalism that's relevant to the medical community. And this is possible due to the generosity of Dr. Arthur Dodek, who endowed some funds and who is here today. So thank you. I don't know if I want to wave. There he is. So I'll just give you a little brief bio of you, Arthur. So Dr. Dodek was a clinical and invasive cardiologist at St. Paul's from 1972 to 2008. And he actually performed the first coronary angioplasty at St. Paul's in 1980 and the first balloon valvuloplasty in 1985. He also had a parallel interest in medical ethics, and he published on the topic, and thereafter was the chair of the ethics committee at the College of Physicians and Surgeons in DC. He also served as president for that organization between 2007 and 2009. So he's established this lectureship in gratitude for his positive experiences at St. Paul's Hospital, and I'm very grateful that he has allowed me to steward this and with a wonderful committee, select terrific speakers to help us learn in this space. So with that, I'd like to introduce Dr. Sarah Andersen. She's an assistant professor in the Department of Critical Care Medicine and a John Dosseter Health Ethics Center at the University of Alberta. So she completed her Bachelor of Science in Health at the University of British Columbia and her MD at Queen's University. She did her residency training at University of Toronto and then did her critical care medicine at University of Alberta. In 2023, she completed an NIH-funded postdoctoral research fellowship and a master's in science in health services research at the University of Pittsburgh, as well as a bioethics fellowship at the Harvard Medical School Center for Bioethics. And so her research focuses on ethical decision-making in critical illness, as well as enhancing patient and family-centered care across the critical illness journey. She currently serves as the ethics co-chair for the Canadian Critical Care Society. So without further ado, I'd like you to welcome Dr. Andersen. Thank you, Sarah. My slides are there. Perfect. Can everyone hear me okay? Yes. Wonderful. Okay. Well, thank you very much for the opportunity to present this year's Arthur Dodek Lecture. I am really honored as an early career academic to be giving this lecture. And although I had not had the privilege of meeting Dr. Arthur Dodek previously, I was fortunate to be introduced to Dr. Peter Dodek when I was a medical student with an interest in critical care and ethics. And he provided some wonderful career guidance that helped set me on this path. So thank you very much for that. So my aim for this talk is to bring together concepts from the fields of medical ethics and social sciences to provoke reflection on how our values and culture, both individually and institutionally, influence medical practice. And in particular, our ability to promote authentic person-centered care. And my hope is that wherever you are in your career, that this talk makes you think in a novel way about medical decision-making. So I'd like to start with a story that some of you may have heard before. So there were two young fish swimming along, and they happened to meet an older fish who's swimming in the other direction, who nods at them and says, "Morning, boys, how's the water?" And the two young fish swim on for a bit, then eventually one of them looks at the other one and goes, "What the hell is water?" And some of you may recognize this from a famous commencement speech by David Foster Wallace. And I like this story because the point is that water is the environment that we live in every day.
right? The invisible structures, routines, and assumptions that shape our lives. And just as real fish don't notice the water they swim in, we humans often don't notice the cultural norms, habits, and ways of thinking that surround us. And so really this story is a reminder to pay attention. And for physicians, the culture of medicine is the water in which we swim. And it's easy to assume that the norms that guide our medical practice are universal and objective, when in reality, the underlying values and assumptions are often subjective and highly contextual. And so as a medical trainee, the situated aspects of medical culture and practice really became apparent as I moved through the various stages of training. And many of you may have had similar experiences or observations. And you've heard that I moved around a lot in my training. And so I was fascinated by how practice changed from place to place. And also by how colleagues and supervisors who had trained and practiced in the same environment often had trouble articulating the values and cultures of their institution. And so, for instance, at the time that I was in training, an ICU patient in a persistent vegetative state might remain on life support indefinitely in Ontario, because physicians there had been very heavily influenced by the Razuli court case and a couple other contentious court cases around withdrawal of life support and provision of non-beneficial CPR. And conversely, a physician in Alberta, which is where I practice now, might decide to unilaterally withdraw life support for that patient and be supported to do so by their institution, influenced by a culture of what is sometimes called prairie paternalism that's still widely accepted in Western Canada. And so, my interest in this practice variation in the ethics of medical decision-making ultimately led me to pursue the training that you heard about in ethics and decision science. So I'd like to start by sort of thinking about how we conceptualize ethical decision-making in clinical practice. Oh, sure. Oh.
I'm hoping that everyone who's on Zoom can actually turn off their camera and also mute themselves, because it is interrupting the speaker. Thank you.
I have some competition. But I'd like to start by stepping back and reviewing what we mean by the term ethics. So ethics can be defined as the examination of the moral life, or right or wrong human conduct. And ultimately, ethics is rooted in values, which are the deeply held beliefs, principles, or standards that guide what we consider important, desirable, and worthwhile in life. And the study of ethics is commonly broken down into three branches. So you have normative ethics, which is the study of how things should be, and strives to develop standards, rules, or principles that guide human behavior. And a lot of the applied ethics work that happens in the hospital setting kind of falls under this heading. And then you have non-normative ethics, which is further broken down into descriptive ethics, which studies what people actually believe about morality without making judgments. And a lot of the empirical research that I'm involved in kind of happens in this space. And then you also have meta-ethics, which steps back to sort of ask, how do we know and justify what is right to do? And contemporary Western ethical thinking really owes a lot to the moral theories of certain Western philosophers like Kant, Rawls, and Mills, that led to the development of the bioethical principles that were popularized by Beauchamp and Childress in their Principles of Biomedical Ethics that really guide a lot of the ethical decision-making that happens in medicine. And so these theories are often referred to as theories of justice, and they're based on notions of individualism and autonomy and concerns for equality and fairness. And the 21st century search for objective ethical truths kind of went hand in hand with the biomedical and scientific advancements in medicine. However, as part of this talk, I'm going to argue that on top of that, we should maybe layer a focus on relationship and ethics on a human scale that recognizes the importance of being attentive to the personal and situational context of medical practice. And this is often called a relational approach to ethics, and it was developed in part by Dr. John Dossiter and Banji Burgum at the University of Alberta. And in their seminal text on relational ethics, they state, quote, "There's a need for a richer moral vocabulary and vision that acknowledges the embodied ethics that can only be experienced between people who carry unique emotion, memory, language, bodies, and culture." And so when people think of medical ethics, they tend to think of large societal debates on things like the right to die or xenotransplantation. But my goal with this talk is to convince you that virtually all clinical decisions have a subjective sort of value-based or ethical component. And so ethics is really inherent in the routine care that we provide day to day. And so to support this claim, I kind of want to draw on the work of a couple of contemporary physician ethicists. And the first is Dr. Edmund Pellegrino. And so he was a physician and Aristotelian sort of philosopher who really believed in this concept of virtue ethics. And I want to touch on his work on clinical judgment, which is, of course, sort of the primary work of being a physician. And he argued that clinical judgments always combined both medical and ethical decision-making. And that's really what sets them apart from scientific judgments. And so in other words, it's the application of scientific knowledge to the care of a particular human being who has intrinsic values and a life plan, right? And it's through that clinical judgment that a person's integrity of self is healed after being threatened by illness. And that's really the purpose of medicine. And so this is just a portion of sort of this schema that he laid out in his essay on this topic. And you can see here that there's an ethical component into the decision in terms of what should be done for this patient. And the word should carries normative weight. This ethical decision takes into account both the patient's values and the physician's values, and there's sort of an ethical discussion that ultimately leads to a consensual decision. And so, you know, this is in every clinical judgment, even the most mundane. Another way that I really like to think about this idea of the ethics of everyday clinical judgments is this idea of microethics. And that was put forth by Dr. Paul Komisarov, who's another physician ethicist. And he described this as ethics that happens in every interaction between every doctor and every patient. And so what might that look like in practice? I say that these are some of the under-recognized ethical choices that we all kind of deal with every day in our practice. So the choice of words that we use when we're counseling patients. So for instance, counseling around abortion, do we use the word fetus or the word baby? How options are framed, whether we frame them in terms of a chance of survival or death. Even how we choose to prioritize our finite time and attention on rounds as clinicians, right? That involves a value judgment about what we value. And you can see a couple others here on the slide as well. And so the challenge, as you can see from the examples that I just listed, is that 100 decisions like this might occur daily for any one of us, right? And so not only does the sheer volume of decisions make it hard to pause and reflect on our ethical choices, but usually, and I think this is really important, there's no overt clinical dilemma or conflict. So we're not cued to pause and acknowledge the values that are underlying our decision making. And so that's great, but why should we care? Because it takes time and effort to reflect on the underlying ethics, and we are all really busy these days. But I think there's a few reasons why this is really important. So first, I think attending to the ethics of our decisions helps us ensure we're prioritizing patient and family values and preferences. I think by being able to explicitly articulate the values that are guiding our decisions, they become more transparent and consistent, which I'll speak to more later. And along with that, it helps us clarify as a profession and a society the values that we want to prioritize. And lastly, it helps prevent important decisions from being made by omission or by default. And default decision-making is a huge challenge in clinical medicine and can create a cascade of clinical momentum that results in care that patients don't want or doesn't benefit them or comes at a tremendous cost to the healthcare system. And we see this very frequently in critical care, and I'm sure you see it in other areas of medicine as well. This is just an example that I really like of what that can look like. And so in this case, clinical momentum, you know, in the ICU leads to a state of what we call chronic critical illness, which is where a patient remains dependent on life support for weeks or months, and they're not really getting better or worse, but they're being kept alive due to a series of interventions that occur, often without deeper discussions about a patient's values. And although in North America, clinical momentum tends to arise from this default decision-making, in this study in the UK, what they found is that there were individual, institutional, and system-level factors that actually led to what they called clinical deceleration, where there was a prevention of potentially non-beneficial treatment escalation in patients living with dementia. And so I think these two studies are a great contrasting example of how organizational influences and cultural values can lead to geographic variations in care. And so I would say rather than allow unconscious defaults to guide our decisions, our role is to help patients make authentic decisions about their care that reflects their values and priorities. And this is really grounded in our Western philosophical principles of dignity and autonomy, as well as utilitarianism and the idea that people know best how to maximize their own welfare. And so our ethical challenge as clinicians becomes, how do we elicit those values and help patients translate them into a particular medical situation? And how do we achieve authentic decisions for our patients? And there's a few reasons why this is a challenge. So the first is that we know from behavioral psychology and decision science that patients often rely on us, whether they know it or not, to translate their values to a medical situation, to generate preferences about what they want for their care. And that's partly because if you think about it, most people lack the trial and error experience with serious illness that might help them develop stable, informed preferences about what they want. So instead, they're stuck trying to construct these preferences in real time using mental shortcuts or heuristics. And when you're faced with unfamiliar decisions and you're trying to use heuristics to make decisions, your choices can shift depending on how options are presented to you. And so that leaves people vulnerable to making decisions that they ultimately regret. And in addition, there are some situations that we face in medicine where there is really no right answer in an ethical sense. And so our job is to help patients navigate complex decisions where even if you have clarity of values, it's not going to provide an easy solution. And in the literature, these have been called both choiceless choices or moral tragedies. So if you think of, for instance, parents who are trying to decide whether to take a child off life support, that might be one of these cases. And so really to do this well, we have to have an understanding of our ability to influence decisions, our own biases and ethical beliefs, and the external norms and aspects of culture that shape our professional values. And it turns out there's lots of examples of literature in the literature of how physician values influence care decisions. And so, for instance, in this first study by Yale, Schenker, and colleagues, they found that physicians were more likely to suggest the option of comfort care when they thought it was the right thing to do. So only a subsegment of patients were being given that option based on what the physician valued. In the second study, physicians basically described care as medically futile in discussions with family to justify rationing of scarce resources, and really these are two different concepts. And in the third study, clinicians differentially described patients as suffering only when they felt that withdrawal of life support was indicated. And in addition, there have been several studies, and I've cited a couple here, that have captured this idea of physician variability and treatment limitation in the ICU and elsewhere. You'll see that most of my references are from critical care, since that's kind of the space I'm in, but you can find this literature in other areas of healthcare as well. And so in the study by Alan Garland and colleagues at the University of Manitoba, decisions to limit life support were more strongly related to the identity of the intensivist than comorbid conditions or the diagnosis of the patient. And Wilkinson and colleagues, also cited here, have called this the roster lottery, whereby the care that someone receives depends on the physician in the roster that they happen to get. And our colleagues noticed this as well. And so this study here looked, the first one at the top of the slide, used grounded theory to identify staff perceptions, non-MD staff perceptions of physician decision-making around withdrawal of life support. A predominant theme was that end-of-life treatment intensity depended on the doctor that was on service. And the second study there was a survey of critical care nurses, and 75% of those nurses felt that physicians had a different threshold to withdraw life support in the critical care unit, and they noticed this, right, when they were practicing. And so it's not always bad that decisions are influenced by the opinion of a physician, but the concern, of course, is that when life-altering treatment decisions depend primarily on the doctor, that patient and family preferences may be neglected. Or as Wilkinson put it in his paper, inconsistency in decision-making appears worryingly arbitrary. And although physician-related variability can never be eliminated entirely, it is potentially ethically problematic. And then beyond individual physician variability, there's also a fairly robust body of literature about how systemic and institutional culture impacts care decisions. And I'm highlighting just two of the many studies on this topic. And so in this first study, Amber Bernardo and colleagues at Dartmouth looked at norms of decision-making about life-sustaining treatments between two academic medical centers in the same health system that had sort of documented differences in practice patterns about treatment intensity at end of life. And they found that institutional norms drove significant differences in how providers conceptualized numerous aspects of end-of-life decision-making as well as treatment. And that extended to what they thought the goals of life-sustaining treatment should be, how they determined that someone was dying, and the emphasis at the institutions that were placed on errors of commission. So, preferentially preferring to be overly aggressive versus errors of omission. And in the second study by Elizabeth Sang and colleagues at UCSF, they interviewed 42 internal medicine physicians across 3 hospitals. And they found that there were direct and indirect systemic effects that led to what they called overly aggressive treatment at end of life. And I've listed some of them here. So the complexity of having multiple teams involved, some of the workflow and time pressures, and the societal expectations in America that kind of drove care decision-making. And so their conclusion was that institutional cultures, social norms, and systemic defaults influence both normative beliefs about what standards of care should be and the treatment plans that are carried out that may not benefit seriously ill patients. And so I hope I convinced you that even routine clinical decision-making is a complex social and ethical process that's driven by the interplay of conscious and unconscious values and norms, and that these norms differ between individual clinicians, institutions, and health systems that leads to practice variation. And further, that variation that arises solely from systemic defaults or physician values could be considered unwanted variation, and that it does not necessarily reflect patient values. And so really the goal of ethical patient and family-centered care should be to become aware of and reduce this unwanted variation. And so in the last half of my talk, I'd like to explore some of the tools that we can use to improve our awareness of the ethical valence of our decisions and our ability to help patients make authentic decisions about their care. So first, how do we become more aware of the water that we swim in, to kind of continue the analogy? And I think that we can draw from social sciences and related fields to really help us make explicit the unconscious value judgments that drive medical decision-making. And much of the work that I've highlighted already and the research that I do draws heavily from social sciences. And so these fields include sociology, anthropology, behavioral psychology, and decision science. And they provide tools and theoretical perspectives that really help us achieve a view from outside that can capture what seems unconscious or invisible to those of us in the water, and really help us determine how patterns of individual beliefs and social interaction and norms impact care delivery. So for instance, ethnography is a qualitative research method that involves in-depth study of a particular group or culture, often through participant observation and immersion. And seminal works of ethnography by medical anthropologists like Sharon Kaufman, whose book is up on the slide, have provided deep insights into how medical culture has shaped fundamental human experiences such as death through the use of medical technology. And I would say a lot of people who are doing empirical ethics research these days in medical practice are trying to embed medical anthropologists in their teams to help elicit some of these complex social phenomena. And so here's one example of an ethnographic study that was done in 4 American ICUs. And this one looked at how inequality in the treatment of patient preferences for use of life support arose. So if you have patients who want different things at end of life, how are those preferences treated by the medical team? And they found that the values and preferences of socially disadvantaged groups who often wish to continue life support for longer in situations where there was a high risk of death were challenged and ignored when they conflicted with the dominant beliefs of the medical team. And I think without the ability to do that degree of in-depth observation, it would have been really difficult to come up with the sociologic observations that kind of help explain this phenomenon. Complexity science is another field that studies complex adaptive systems and looks at how multiple interacting components create emergent patterns and behaviors. And it's a complex diagram. It's a little small up there, but I would refer people to the paper because it's really quite interesting. And so this is an interdisciplinary approach that uses various concepts and methods to understand systems characterized by interconnectedness, adaptation, and self-organization. And so in this study, complexity science and human factors engineering were used to capture the complex process of decision-making about intubation and mechanical ventilation for critically ill patients. And the nice thing about this approach is that then you can hone in on any step in this process if you want to design some sort of intervention to improve care. And so lastly, mental modeling is a research method that's drawn from the field of decision science. And this is, the idea here is that people's judgments and decisions are influenced by a tacit web of beliefs that develop over time based on their experiences, their observations, their values, and their education. And so the conscious decision that any one of us makes or can articulate is really only the tip of the iceberg in terms of what's driving our decision making. And so the goal of mental modeling as a qualitative method is to define and make explicit that web of beliefs that's under the water. And this approach is really pioneered by Dr. Baruch Fischoff, a decision science researcher at Carnegie Mellon. So here's one example of what that can look like. So this is surgeon decision-making about emergency general surgery for elderly patients. And you can see that the ultimate decision about whether or not to go for surgery is preceded by a number of steps in the decision process, and that all of these steps are influenced by a complex network of multiple factors that extend beyond sort of the purely medical facts. In my postdoctoral work at the University of Pittsburgh, I had the opportunity to work with Dr. Fischoff and use this methodology to better understand how intensive care physicians approach goals of care conversations in chronic critical illness, which is that condition that I mentioned at the beginning of the talk, where we know that care often occurs without a concerted effort to understand patient values and preferences. And so by interviewing intensivists across a number of institutions, we arrived at a mental model that kind of captured the factors that physicians considered when approaching goals of care decisions in chronic critical illness. And you can see that we conceptualized the process of navigating goals of care decisions from the physician's point of view as involving two distinct steps. So first, the physician has to recognize that there's a decision point where you have to think about goals of care, and then they have to formulate an internal judgment and provide a recommendation, about how to move forward with treatment. And as you can see, there were several factors that influenced this process, and these factors extended beyond patient level factors, prognostic factors, to also include physician characteristics, relational factors, and health system specific factors. And then beyond that sort of set of primary factors were a number of other secondary factors that further influence the decision. So you can see that this is a very complex process. And so these two studies basically provide an example of how mental modeling can be used to capture and analyze the values, beliefs, and assumptions that inform medical decisions. And I think the beauty of this type of methodology is that you can create these mental models not only for physicians, but also for patients and families and for other stakeholders within the health system. So it can really be a powerful tool. And so now, moving from research to practice, I'd like to highlight how shared decision-making as a structured approach to care decisions can help us promote authentic patient decisions. So shared decision-making is often defined as a collaborative process that allows patients or their surrogates and clinicians to make healthcare decisions together, taking into account the scientific evidence and the patient's values, goals, and preferences. And I think many of us incorporate aspects of this into our practice, but may not do so explicitly or formally. And so if you think of clinical decision-making as existing on a spectrum of ethical potency, where you have sort of routine clinical decisions on one end, and then high stakes sort of life-altering decisions on the other end, shared decision-making is most useful for those decisions that are highly impacted by values. And these are often called preference-sensitive decisions, where there's this concept of dual equipoise, where both the clinician and the patient are uncertain about how to proceed, and where there may be two or more valid approaches, and the risks and benefits of each one depend on the values of the people involved. So we know that shared decision-making from the literature can increase trust in the medical team, satisfaction of care, patient understanding and engagement, and decrease decisional conflict, and improve communication. And typically it's conceptualized as this bidirectional dyadic process between a clinician and a patient, with this reciprocal sharing of information and then a collaborative decision. And that's in contrast to these unilateral approaches like paternalism or consumer-directed healthcare. But unfortunately, in practice, it's not quite that easy. And so you can see that there's a large number of steps involved to really do this well. And they're not always emphasized, I would say, in the literature. And so, the first one is you need to establish a trusting relationship. You need to help support patients through the emotions that can overwhelm their ability to make decisions. As I've touched on before, you have to recognize that there's a decision point. Then you have to prognosticate to provide patients with that important information. Do the information sharing that I talked about. You have to clarify how the patients want to be involved in the decision-making process. And then ultimately you make a decision. So it's quite involved. And again, this is something that we found in our work on goals of care decisions in chronic critical illness from physician interviews, that they described doing this process for goals of care in chronic critical illness to be complex, iterative, and longitudinal. And it involved multiple stakeholders, multiple steps. And I would say that this type of diagram, capturing shared decision-making in the real world has been replicated in other spaces like cancer care and geriatrics, thinking about making decisions for elderly individuals who may not have capacity, for instance. And I just wanted to touch on a couple of those points that are particularly challenging in this process, right? So as I've already said, recognizing that there's a decision to be made is really important. And patients often rely on us to recognize that. And if it doesn't occur, that's where we get this unwanted clinical momentum or decisional inertia. Again, eliciting values can be challenging for the reasons that I discussed earlier, and that people lack this trial and error experience to be able to make stable, informed preferences. So it's not as simple as just asking the patient, what they value or what they want. And prognostication is another challenge in medicine that we probably don't talk about enough, but it's vitally important information for patients to be able to make authentic decisions. And one of the challenges is the way you get good at this is, to do the same thing repeatedly, and then get prompt feedback on your performance. And that's not really what happens in the clinical setting, right? In many cases, we don't get feedback on the counterfactual decision and outcomes that could have been made. And we don't find out about critical outcomes for surviving patients, things like their quality of life or their long-term functional outcomes, or we get the feedback so late that we can't really reconstruct, how it influenced our decision-making when we were making decisions. And adding to that difficulty, not only do we have to prognosticate around survival, but we have to prognosticate around functional status and quality of life, right? And although we should be evaluating quality of life based on what an individual wants for themselves, what we call sort of an interpersonal approach to quality of life, it's really easy to fall into judging quality of life in an interpersonal way. So based on our own metric of goals and values. And we know that we're notoriously poor at predicting someone else's quality of life. And I really like this study. So here they asked critical illness survivors to rate their 6-month quality of life, and then they compared it against clinician predictions. And what they found is that critical illness survivors were split in terms of whether their quality of life was better, the same, or worse after being in the ICU. But I think importantly, the clinician predictions were pessimistic and they had very low discriminative accuracy. So basically no better than a coin flip to be able to judge the quality of life. So given this, I thought maybe I'd just provide some evidence-based tips around how we can do this well. And so the first tip that I wanted to propose is that, again, we need to be mindful of decision points since patients and families take their guidance from us. And so to do this, it's helpful to consider triggers that signify important decision points in someone's clinical journey. And that can be high stakes treatment decisions around things like tracheostomy or dialysis, major surgery or amputation. Transitions in care is another opportunity where we should be sort of thinking to ourselves, is there a decision that needs to be made here? And time is another one to consider. So someone who's been in the system for a long time, maybe there's an opportunity to have a discussion about how to move forward. Second, given that patients can struggle to articulate their preferences in stressful or novel medical situations, I think it is helpful to start to try to understand the deeply held values of our patients, which may be more clear. And one way to do this has been proposed by a palliative care physician and geriatrician, Leslie Schuneman at the University of Pittsburgh. And they call this a facilitated values history. And this sounds maybe a little nebulous and time consuming, but eliciting values and serious illness communication in general is a highly learnable and teachable skill. And so, I often say to learners in the ICU, it's just like learning any other procedure. And there are structured tools and training programs that exist. And so here I've highlighted one of the frameworks to help elicit values that comes from the Vital Talk training program. And this framework is easy to learn and remember, and we now teach this approach to all our critical care fellows in Alberta. And anyone can sign up to do the Vital Talk training. And there are other training programs as well, like the Serious Illness Communication Guide training that has been widely adopted by many health systems. And I think a structured framework can also be really helpful to ensure the options presented are being presented in a balanced way. So this is another one I really like that some of you may have seen before. This is called the best case, worst case framework. This was developed by Dr. Gretchen Schwartzy. She's a surgeon and an ethicist at the University of Wisconsin. And so the idea here is that a clinician presents two proposed treatment options and then their prediction of the best and worst and most realistic outcome for each treatment path. And so this allows the patient and family to have a sort of more holistic sense of the options that are before them. I also think the importance of multidisciplinary teamwork cannot be overstated. And so, shared decision-making is about more than just medical prognosis. And so to achieve a holistic understanding of patients, we have to work collaboratively. And a patient or family may share important insights and wishes with the bedside nurse that they don't share with the physician. The physiotherapist has a piece of information about the functional prognosis. The social worker knows what community supports are available, and whether the patient can achieve their acceptable outcome in the community. And so integrating interprofessional models of shared decision-making, I think, is really important. And lastly, I think if there's significant uncertainty, whether in values or prognosis, allowing more time before making a decision, if possible, can be really helpful. And some of you may be familiar with this idea, but it's fairly new, so I wanted to highlight it. It's this idea of what we call a time-limited trial. This is something in critical care that's sort of becoming more widespread. And so the idea here is that there's a deliberate agreement between clinicians and families or patients to treat for sort of a defined time interval and evaluate for success of that treatment based on explicit criteria that are agreed upon by both groups. And so this approach is still kind of being refined and studied, but many people think it has the potential to counteract both inappropriate nihilism, which can be something that we fall into, or unchecked clinical momentum. And so to end, I'd just like to step back and kind of return to this concept of relational ethics. And consider how a relational ethic of care can help us shape the systems in which we practice to promote authentic and deliberate human-centered care. And so in their seminal work on relational ethics, John Dosseter and Vanjie Burgum had developed this concept of the relational space. And this is defined by themes of mutual respect, relational engagement, and embodied experience, and acknowledges the complex relationships that exist between patients, clinicians, and caregivers. And so I really think this concept fits well as a way to address the myriad of values, assumptions, and beliefs that shape care. And a huge aspect of this is that it implies really an understanding of ourselves, right, and what we bring to that relational space. Practically speaking, how do we do this? How do we create this relational space? I think the tools are both simple and demanding. So they're things like, humility, self-reflection, openness, and curiosity. And these aren't tasks to be completed, but they're really an intentional way of existing in the clinical space. And I think part of that ongoing lifelong practice as a clinician to try to develop these characteristics in ourselves. And this relational approach to ethics, I think, also acknowledges the fact that autonomy is a relational experience. And so none of us make decisions in a vacuum. And so we really have to be mindful of the ways in which our actions and interactions can promote or hinder patient autonomy and authenticity. And so I'd just like to end with an idea by Dr. Harvey Chochnov we were talking about earlier. And he's a really wonderful palliative psychiatrist at the University of Manitoba. I understand he came and spoke here recently. And, he's really written about this idea of the platinum rule as an upgrade to the golden rule. And he may have talked about this when he was here, but it's based off his experience with the care that was provided to his sister who has cerebral palsy. That he found somewhat discriminatory and discounted the possibility that she might have an acceptable quality of life as a person living with disability. And so the idea is that, we should be doing unto others as they would want done unto themselves and not presuming that we know what's in their best interest based on what we would want in their circumstances. And so in the past 50 minutes or so, I hope I've convinced you guys that all medical decisions, even the most routine, involve values and ethics. And to help patients make authentic decisions, we have to understand the influence of our own values, norms, and culture, and that social sciences can be a really powerful tool to help us achieve that. And that humility, self-reflection, and the co-creation of a relational space through shared decision-making can help promote ethical care, and that this is something that can be learned and taught, and that we can kind of continue to strive for in our own practice. And I will end there. Thank you.
Thank you so much, Dr. Andersen. Are there any questions from the Zoom landscape? You can unmute and ask them. Okay, I will take any questions from the audience or comments. Dr. Boyd.
Sarah, enjoyed that. Thank you. That's I'm working the ICU at times here, and I really like the momentum model. This is more of a comment, but I would like your comment. But I think the acute care hospital is built to have a medical trigger, and of course, the easy way for this for the intensivist and internist and so on. The least energy is increasing momentum. And I'll just, for interest, we have a group meeting of all our intensivists once a month where we discuss what we call challenging cases who generally are chronically critically ill. Mm-hmm. I would say our the standard variation across, we'll be unanimous almost always in recommending, that we strongly think there should be palliation. But as to your comment, it's extremely diverse who will put the effort in to get there. Just something in your models, which it doesn't necessarily, I think the comment is it's not necessarily our values as clinicians that we think it's right or wrong, but there also is how much effort are you willing to put in to stop the momentum? And that's a huge variability, not just ICU, but.
Yeah, totally. No, I appreciate that comment. And I think this is for me where this idea of what are the structures and the norms and the institutions that are facilitating or hindering our ability to act, right, in a way that's congruent with our values and the values of our patients. And that's part of the work, the reason I love the work Elizabeth is saying as a medical sociologist, because I think obviously in our individual care, we need to be mindful of how we can create the space to be able to put in the effort, but how do we also alter the systems that we work in to decrease the resistance to do that? And so I didn't really touch on this, but for instance, with the chronically critically ill patients, one of the huge barriers is the time involved to go back and review all the medical documentation that exists for that patient. the documentation of prior conversations that may have happened. And are there ways that we can better design our electronic health record to make it easy for people to pull up the record of goals of care conversations that have happened in the past, so that we can go into our interactions with patients and families with a better understanding of that context, so that it's easier to jump into those conversations. Yeah.
Thanks.
Dr. Casson.
Thank you for the presentation. It was excellent. Could you comment on our organization as healthcare providers and how it influences our decision making? And just the example is, in different parts of the hospital, teams work a week at a time, or a day at a time, or 8 hours, or not on the weekends. Or so how does that reconcile with the things you're talking about?
Maybe repeat the question.
Yeah, sure. So the question was around how our organization as healthcare providers and sort of our shift models and transitions in care influence our ability to kind of carry out some of these values-based approaches to care. And I think it has a huge impact. So again, we've found that in our research, and other people have as well, that one, having, for instance, 1 week models of service is what we have in the ICU, really makes it difficult to build the trusting relationships with patients and families that are necessary to really make shared decisions in complex medical situations. And those handovers also mean that there often isn't enough time to really truly understand the medical situation of the patient, particularly given the complexity of our patients these days, to be able to, again, build those relationships and have really meaningful conversations. And I think this is where, ideally, if you have a longitudinal provider in the community, there's someone who should be having these conversations or should be brought into these conversations in the acute care setting to help mitigate some of those challenges in the acute care space, particularly as our care becomes more complex and more fragmented. But I think it is a challenge, and there are obviously downsides with shifting our staffing models, because I don't think it's sustainable these days for someone to work 1 or 2 months at a time in an acute care environment nonstop. So again, this is where there are ways we can do our handover better. I think the idea of having these sort of weekly multidisciplinary meetings, or meetings that allow us to develop a richer sense of the patient, can be helpful, so that we have that, it's been called transactional memory as a health system, to be able to really know our patients and support them better.
Peter.
Thanks very much for your presentation, and particularly for all the tools to help caregivers. My question is about metrics. What is the best measure in the current era of decision making, of a good decision? I know that in the ICU we have the FSICU, which is half of it is about decision making, but I'm just curious. And just a little side note about satisfaction with family needs, and it's related to what you presented. You're probably aware of, you mentioned time. Some years ago, folks studied family satisfaction with meetings with ICUs, physicians. And the satisfaction was inversely proportional to the amount of time the physician spoke.
Yeah.
So listening is probably also another.
Yeah,
anyway,
totally.
My question is more about the metrics.
Yeah, that's a great question. So for people online, it was a question about what are the best metrics to evaluate decision making? I think that is still an active question. I don't think we have an answer. So I think there are a few things that are important. In the empirical literature, you'll see decisional conflict being used as a measure. So how conflicted do people feel about their decisions at the time that they're making them? But that really doesn't pan out well with how people feel about their decisions and their outcomes long-term. So I don't think that is the best metric. Decision regret is another one that, we've looked at. I looked at when I was working with Doug in Pittsburgh. And I think maybe that's a little better, because people have to live with the decisions that they've made, either for themselves or their family, but it's still not perfect, because there's lots of things that factor into regret that have nothing to do with the decision you made at the time, because the outcomes, may be poor, but the decision you made may have been the best one you could have made in the moment. So that's also a challenge. So I think it's some combination of making sure that the decision-making process is robust. And I'm not sure that decisional conflict is the best measure for that. Maybe that measure still needs to be developed. And then also how people feel about it long-term, which may be partly based on regret, but there may be other components of that as well that still need to be investigated. Maybe the psychological distress that people feel over time or don't feel, whether that's mitigated by how the decision-making happens. I think some of the work that Dr. Chashnov has done on dignity and, whether people feel they're seen as a person and supported through the decision-making may be important. And I'm not sure that we're always capturing that. I hope that partially answers your question, which was very challenging.
Anthony, Dr. Gedda.
I thank you for that excellent presentation, specifically about the ability for healthcare providers, intensivists, and nurses to prognosticate how well, in a very patient-centered sense, how well was the intervention received. I can't remember if it was 3 or 6 months. I mean, it seems like, the toughest thing to predict is the future. What should I do? Not like knowing that I don't know. From relatively easy things, is this drug going to work versus should we escalate to life support? Again, are there a group of providers that, within that mass do have a good anticipation, or are we all just really just at a coin toss? We can't.
Yeah, no, that's a great question. I know it's kind of a discouraging study in some ways, but I think, I think there's a couple things. I think the first is this importance of having humility, and this is where it's so important to be mindful of our own biases and values when we're going into these conversations with patients, so that we can never eliminate them, and nor should we. But I think being explicit about where our recommendations are coming from when we're talking with patients and families is important, so they have that information as well when they're trying to make decisions, right? If we say, my bias as an intensivist is that I see a lot of people who die on life support and it's not the death they would have wanted, so I worry about that, but you as a patient might worry about not giving it a shot, and that might be what down the line you regret, for instance. And so just making that explicit. I also think there's a role to bring in more community providers into these conversations who see patients down the road. So in critical care, that would be people like physiatrists, or in the States, they have these long-term care facilities called LTACs, and there are physicians that work in the LTAC system. So bringing them into the conversation to say, okay, if you have chronic critical illness and you have a trach and you're living with it a year on in one of these facilities, what does that look like? What kind of recoveries do we see in that time scale that those of us who work in acute care don't see? I think that might be one way to help refine our prognostication. And then again, I'm very interested, and other people are as well, in this idea of sort of group refinement of prognostication, that in these really challenging cases, or for those of us who are more junior and haven't seen as much, that we have these discussions with our colleagues, and we have these multidisciplinary discussions to say, look, this is what I think the prognosis is going to be for this patient. Do you guys agree? Do you feel differently? Have you seen cases, where things have gone in another way? And that can check maybe some of that nihilism or optimism.
This is a follow-up. Do you know of any work from more of an actuarial science standpoint where, if they say, well, what's my likelihood of being able to go home and play with the kids? And people with this profile don't or do or this percent.
Yeah, I think that's a great point. Thanks for bringing that up. Yeah, I think some of that data exists for individual conditions, and I think that there is a need to capture more long-term outcomes data. Again, I work in critical care, so that's where my lens is, but in critical care for sure, we need more long-term outcomes data, and more broad data than just specific populations. So we have like the post-cardiac arrest population. We're starting to get some of that long-term data, but chronic critical illness, we have some, but there's probably still more that we need to capture. And I think that helps. And there are prognostic models now that you can sort of plug your patient into. I know UCSF has done a lot of work in that space. I don't think they'll ever solve the problem entirely because every patient is unique and we get these overlapping situations of multiple different types of pathology. So you're never going to be able to hang your hat on that. But it is one other tool that can be helpful. The interesting thing, actually, as an aside, is that those types of decision tools have been studied a little bit to help people make decisions in critical care. And they don't always help. So people can see the prediction from the tool, but still say, well, I don't believe that prediction because my loved one is different, right? And so you never get away from having that human conversation about the person and their values.
Ken, I think was first, then Rose.
I was wondering, like the best provided patient-facing information that they can use to like voice their values, like find like the parts of the meeting kind of do implicit values, prognosis, and all these things, like some kind of thing, like and then with that, like trade-offs that they would take to achieve those values, like some kind of not a workbook, but like if you do this for cardiac surgery, you get a book, you get this like some kind of material that the family and the patients can work through, because often we have a lot of talking to families in the ICU after, they said, well, they said do everything, so I guess that's what you should do.
Yeah.
But they didn't say do it so I can get home, and again, they said, like, I always wonder about people getting in, they didn't do that. Here's the reading, and someone's going to come off with it. I know we're starting to try to do that on the board, like on the radiology board. I was just wondering if there's out there, why is this not being used?
Yeah, that's a really good question. So it's around resources for patients to help them reflect on their values. So I think there are some tools. The Serious Illness Communication Guide has, I believe, patient-facing resources, and that's a really great, robust, evidence-based model. And there, in Canada, there's the myconversations.ca website that again has these workbooks. A lot of them are more focused on advanced care planning, but I think it's the same principles. And ideally, people should have the opportunity to reflect longitudinally over what's important to them, right, to help develop those stable preferences. So those are two resources that come to mind on the top of my head. And I know there's work being done at the University of Washington, again, trying to pair a patient and family facing worksheet that they were given before going into a clinic visit that allowed them to kind of prompted them to think about these topics. And then a clinician facing sheet that had prompts for the clinician to help them think about it. And I believe the clinicians also got to see what the patients and families had written ahead of time so that then they could have a conversation. No. Yeah, it's a good question. I don't know if I have an answer to that. I mean, I think some of it is institutional inertia, right? Like, I think it's really hard sometimes to implement these system-wide initiatives and to get buy-in. And historically, although I think that's changing, getting institutional buy-in around serious illness communication has been difficult. And some of them are still experimental or they haven't been studied. Yeah, and again, like I think, again, part of the challenge is it's never going to be enough just to give them the piece of paper. There always has to be like a discussion. But yeah, as a starting point, totally agree. Yeah, and actually there are some web-based programs that are being developed as well, but I believe they're still in study. They're not actually commercially available.
So Rose, last question.
Are you sure you need it? Because I'm okay, I can do it.
I think you want to hear your question.
Thank you so much for the talk. Super interesting. Learning how you care about. I'm really interested in theory, conceptual frameworks, etc. And Anita began the talk with Indigenous land acknowledgement. Relational ethics has always struck me as Westerners coming along and claiming a space that Indigenous cultures have founded their way of being on for time immemorial. And so I was just very curious, in the literature, in the space you work at, is there any work being done using an Indigenous worldview, a very different water that people would swim in?
Yeah.
They actually help all of us in how we relate to people and talk to people, that could advance these conversations instead of continuing to try and force it down this Western, westernized kind of worldview.
Yeah, no, that's such a great question. It was around Indigenous sort of frameworks for relational ethics and what we can learn from them. And one, I totally agree with you, and I think there's so much that we can learn. I have to say that I personally have not really come across that yet in the literature and in the world that I work in, not even at the University of Alberta, where we do have a fairly robust, Indigenous, representation and sort of research space, that I have not seen that yet. I think what I've seen is we're still at the point where we're thinking, oh, we should better try to understand the experiences of our Indigenous patients, right? And still looking at it through our lens and how are they experiencing the systems of care that we've put together. And we still need to take that next step to what can we learn from those ways of being. Yeah, I would love to see that. Mm-hmm.
So if we could give Sarah a round of applause, and thank you so much. And I think next week's talk is from VGH, and I wasn't privy to what it is, but there should be grand rounds next week. Thank you. Thank you so much. That was really great.